Lung cancer is a very dreadful disease. Every year we have more than 230,000 patients develop it, and 150,000 die from this disease. That's the equivalent of the whole population of Kansas City, Kansas, dying every year. It's a huge healthcare problem, and it's a healthcare problem that we have just started to improve over the last few years. Despite having a very effective screening test as low-dose computed tomographies, fewer than 2% of eligible patients in this country actually do get this screening test. And we know that from an abstract that was presented here at ASCO a couple days ago. My talk has a subject, patients with more advanced disease, for which the disease is even more dreadful, because most patients historically died within 12 months. What we have seen over the last few years is that a combination of new agents, including targeted agents and immunotherapies, has helped patients live a little longer, but we still have a lot of effort and a lot of work to do. The specific presentation that I'm showing at the plenary session later on today is a comparison of an immunotherapy, an immune checkpoint inhibitor called pembrolizumab, which blocks a molecule called PD-1, versus standard chemotherapy for patients who had advanced non-small cell lung cancer and who also expressed a marker called PD-1, which has helped us see in the past which patients tend to do better, and that's why we wanted to test this population with patients with an expression of at least 1%. And this is what I just mentioned to you in this background. It's important to notice that in this trial, we did not enroll any patients with EGFR mutations or ALK translocations who would actually have been better candidates for tyrosine kinase inhibitors, which are oral targeted agents. And these are the main results of the trial. In this trial, we sequentially tested 3 different populations with expressions of 50% or greater, 20% or greater, or 1% or greater. So the slide that you do see is the slide for the whole population of the trial. And here we see that the overall survival improved from 12.1 months with chemotherapy up to 16.7 months with immunotherapy with the agent pembrolizumab. For patients that have an expression of 20% and above, those numbers are actually 13 and 17.7 months. And for patients who expressed at least 50% of PD-1, the median survivals were 12.2 months and 20 months. In addition to that, those patients that had responses to pembrolizumab had responses of much longer duration, as we see in this slide. The figures show you the responses for chemotherapy in orange and for immunotherapy in blue. You can see that those numbers are overall very similar, but if you see below the bars, you can see the duration of response, which varied from 10.8 to 20 months for the patients with a tumor proportion score of 50%. And I'll mention also for the group of 1% and above, for which the duration of response went from 8.3 also to 20.2 months. And these are responses that are unlike anything that we have seen with chemotherapy in the past for non-small cell lung cancer. In addition to that, and probably more importantly, patients had fewer adverse events. Overall, about 60% had any treatment-related adverse events with pembrolizumab versus 90% with chemotherapy. For severe treatment-related adverse events, grade 3 or 5 as we call in the trial, only 18% of patients in the pembrolizumab develop those severe side effects versus 40% for patients who received chemotherapy. And these are our summary and conclusions, and we have more data that we'll present in the afternoon, and we're looking forward to the discussion, but we can come to the conclusion that pembrolizumab becomes an option for patients who have advanced non-small cell lung cancer who do not have EGFR mutations and ALK translocations, and who do express PD-L1 at least the 1% level. We do need to do a lot more work. Even though patients do better today, they still do not do well enough. The vast majority of patients with advanced lung cancer will have disease progression and will succumb to lung cancer, so we do need to continue doing a lot more work. We are seeing new studies at this ASCO as well, using combinations of chemotherapy and immunotherapies. We are looking at combinations of immunotherapies, and we hope that in the next few meetings, we're going to see results that are even better than the ones I'm showing here today. For your time and attention, I thank you.